Hi everybody, my name's Suzanne Gibson. I'm from Eastern Melbourne, PHN. I hope you can all hear me. We'll just let everybody jump in. Okay. The numbers seem to have settled for a moment, so I'm going to get started. So as I said, my name is Suzanne Gibson. I am one of the program facilitators in the GP engagement team at Eastern Melbourne, PHN. I'd like to welcome you to our webinar today. We're looking at the nurse's contribution to GPCCMP development and patient engagement. I'd like to begin with Eastern Melbourne acknowledging the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. Eastern Melbourne PHN is committed to the healing of country, working towards equity and health outcomes, and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. So I'm just going to go through a little bit of housekeeping for this webinar. All attendees are muted and you won't be able to turn off your microphones. We are going to have a Q&A at the end, but if you put any information into the chat about Q&As, please be mindful that you don't use any patient identifying information in your participation. And as I said, we will have a Q&A, but it will be by the chat box only. So please feel free to put any questions you have into the chat box. This session is being recorded, so if you wish to have your cameras off, that's absolutely fine. And at the end of this event, actually sometime next week, we will be sending out the recording link and a copy of the slides in our post-session correspondence. So just a reminder, please do not use the Q&A section for asking questions. Please use the chat section, and also please don't use any AI transcription services to take notes during the actual presentation. It's quite distracting to the presenters, and you are more than welcome to use any AI notes transcription services on the recording after we've sent it to you. So our agenda today is to have a look at the strengthening Medicare reforms for chronic conditions management, the why and the what of the reforms that have taken place. We're going to have a couple of case studies, so practice in action from our presenters. We're also going to go through making it work in your practice, some tips and tools, and we'll have some time for questions at the end and hopefully some reflections upon care as it's being presented at the moment. I would just like to stop sharing for a moment and introduce the speakers. So we have two speakers presenting today. The first is Dr. Paresh Doda, who is the Principal General Practitioner and Director at Prestantia Health. Paresh is a GP with a diverse portfolio encompassing clinical practice, academia and advisory roles. He focuses on chronic disease and palliative care and is passionate about purposeful innovation in primary care and to improve outcomes that matter to patients. Our second presenter today is Kylie Foley, who is a practice nurse and diabetes educator at the Hills Family Medical General Practice in Sydney. Kylie has worked in primary care for the last 12 years, and she's a nurse immuniser and a credentialed diabetes educator. This year, Kylie has commenced her training as a nurse practitioner at the University of Newcastle. Kylie is passionate about diabetes management and helping people improve and manage their own health. Okay. I'm going to start sharing again, and welcome Paresh and Kylie, and I'm going to turn my microphone off, and thank you for your presentation.
Great, thank you, Suzanne. Thanks for that introduction, and thank you to all of you for joining us. So as Suzanne said, we're going to sort of go through, the next 35, 40 minutes, really going through a bit of a narrative around chronic conditions management plan. We're going to start with the why, because I think we've got to just take a step back and look at, why on earth is chronic condition management important, and why are care plans an important component of that? So we're going to sort of look at that, and then move on to case studies, and then sort of think about how can we practically apply some of this thinking and thoughts into practice. So Kylie and I will kind of share, and we're from different practices, so we'll kind of share thought bubbles and ideas from our respective practices, but also what we've seen work out there. I guess one of the things I would like you to sort of think about as we're going through our presentation, and we can pick up on some of it during question time, is sometimes we see, the quality of a care plan, the importance of a care plan, and delivering that value of a care plan. It often requires time, it requires coaching skills, it requires sort of commitment. So that's really important. And sometimes we see a tension between getting that quality of the care plan versus the busyness of general practice and time and sustainability. And so as we go through the presentation, maybe just hold on to that thought around how can we do this as a team, and how can we make it sustainable and useful for the primary purpose of getting better outcomes for our patients, but the secondary purpose is around practice sustainability and improving the revenue for the practice and the clinicians. But let's start off with that why question. So if we look at the next slide, you'll see, why is chronic condition management important? And you don't really need me to tell you this. Most of you know this. More and more Australians are living with a chronic condition. If you look at the AIHW reports, they kind of tell us this. And when we look at the projections and predictions of the growth in chronic conditions, that's going to be, it's frightening in some ways. If we look at hospitalizations, 55% of all hospitalizations are related to a chronic condition. If we look at the length of stay in a hospital during an admission, when a person has a chronic condition, particularly heart failure or diabetes, they're likely to stay in longer than if they didn't have a chronic condition. And given the the chronicity, the chronic nature, the longitudinal nature of living with a chronic condition, and given the longitudinal relationship general practice has with patients, we play in primary care a pretty crucial role in the management of these chronic conditions. And in a moment I'll present some evidence around this. When I think of this, I guess there's two fundamental questions that come to my mind, and these are on the next slide, right? So the first fundamental question for me is, does a care plan actually make a difference? And that's a bit of a leading question, because the answer is going to be yes, and I'll explain to you why in a moment. But if it does make a difference, what is it about the process and the components of a care plan that actually make a difference? So we're going to tease that out in the next few slides. Let's start with that evidence base, general practice and care planning making a difference. If we look at this next slide, this is actually real world data. So it's not research data, it's real world data. And this real world data comes from New South Wales, where there's been a data linkage process for a number of years now, linking data sets from general practice, MBS, PBS, hospital, ambulance, community health services, death registries. So like all these data sets that exist normally in silos have gone through an ethical process, and they've been linked. And having done that, it's called Lumos. And what Lumos have done is they've shone a light. They've gathered some insights around what insights we can gain from these linked data sets. And there's a couple of really, really interesting insights, I think. So if you look at diabetes as an example, and this is a really detailed slide, but I'm going to ask you to focus on the bottom right-hand corner of the slide. You've got two columns: people with a diagnosis when that's first recorded in general practice. So, we've perhaps done a preventative health check, we've identified and diagnosed the diabetes, and then we're managing the diabetes. The column on the right is when the diagnosis is first recorded in hospital. So somebody's had an admission and the diabetes has been diagnosed in hospital whilst they've had that admission. And I draw your attention to the outcomes. So these sort of two rows at the bottom, okay? And what you see over a couple of years is when we diagnose diabetes in general practice, we look after them more in general practice than when it's diagnosed as well elsewhere. They have less hospital admissions, and they have less use of outpatient services, and they have less mortality over the 2-year period as well. So this to me kind of is really quite compelling data. It's observational data, but it's data from a huge data set, 2 million records, right? 2 million plus records, which kind of points to the fact that if we do things in general practice and we look after people, if we make the diagnosis and we look after people in general practice, then there are better outcomes. If we look at the next slide I think is another really interesting insight, and this is around continuity of care. Does continuity of care make a difference? And the way they defined continuity of care was to look at practices that had high connectivity with their patients. And by that, it wasn't like massive. I think it was, and Kylie will correct me if I got this wrong, but I think it was 12 consultations over a 2-year period was defined as a high connectivity practice. Anything lower than that was a low connectivity practice. And what they found was across all age groups, the return on investment for those high connectivity practices, because when you had higher connectivity, you are less likely to be admitted to hospital, you're less likely to go into outpatients. If you were admitted to hospital and you were discharged, you're less likely to be readmitted. All those things represent a saving to the health system, and the return for every dollar we spend in general practice to the system is 1.6 across all age groups. And you can see when you look at older people that that return on investment's pretty high. So I think those two slides for me answer that question around why is care planning important, and provide real world observational data that it makes a difference. And Sophia said that the next question then is, what is it about a care plan that actually makes a difference? And the next slide really details this out. Okay, there's not one piece of research that tells us this. There's a number of different pieces of research. And so on the right-hand column, you can go to where the evidence base is. But having patient-centered goals in a care plan absolutely make a difference. And I think having a nurse doing a care plan with the GP around shaping this patient-centered goals is so important and so critical. Having a comprehensive care plan, so the care plan is not just about the COPD or the epilepsy or the hypertension, but it's actually comprehensive. It's about all the diagnoses, all the illnesses. It's about the conditions I have now, but it's also about the prevention. That comprehensiveness makes a difference. And it's not just about medical stuff, right? It's about the psychosocial stuff and the functional stuff. So what are people able to do? What are they not able to do? What's the emotional well-being like? What it's not like? What are the social care needs? What's preventing them from better looking after their own health? All of those things, again, help us in a care plan to make it a more impactful care plan. Medications play a big role, and obviously, people with chronic conditions and the growing multimorbidity we see are on more and more medications. So getting the medications right, having the list correct, having the doses right, knowing whether people are taking the medications as they're supposed to take them, that the medications are being monitored, all of that forms an important part of a care plan. And again, contributes to it being more impactful and making a difference. Ultimately, when we're doing a care plan on a person living with a chronic condition, which we're also doing that secondary and tertiary prevention stuff, right? So we want them to stop having another event. We want them to stop having another heart attack or a stroke or the kidneys failing or an amputation. So the lifestyle interventions that go hand in hand with doing a care plan are important from that secondary and tertiary prevention perspective, as well as the medical stuff. Ultimately, if you look at how long a patient living with a chronic condition spends with us, with, other specialists, it's actually a really small time. Most of the time, they're managing the condition themselves. And so supporting people to better look after their own health, having that sort of education, knowledge, skills, but also the confidence to look after their own health is a really strong part of the process of care planning. And that's why, in my opinion, like having it done with a practice nurse there. So I think practice nurses are amazing at perhaps bringing these coaching type of skills into the conversation to help patients better look after themselves is fundamental. With, again, multimorbidity, joining up care for people, knowing when they go and see different people, when they're going to have their blood test, when their follow-up is, when their immunizations, preventable immunizations are, when the cancer screening stuff is due, capturing all of that information into a care plan, into a sort of coordination table, and who else is involved in the care of that person and their role and having the referrals in place. Again, a really important component of a care plan. None of that matters unless there's a review and follow-up. And that's one of the fundamental reasons, we've had the change in July around chronic conditions management plan, because when we did GPMPs and TCAs, we did them, but the evidence was they weren't really being followed up. So the idea of changing to the GPCCMP was to at least financially incentivize a follow-up being equivalent to the creation of a care plan. And so having that follow-up schedule is really important. Again, a care plan is useless unless it's shared. And so documenting in language patients understand, in a language others understand, and then sharing that broadly with the patient, with the carers, with the rest of the care team, and using maybe My Health Record as a vehicle to help us do that, again, makes it more impactful. And patients need to be an active participant in this, right? So consent and activation is a critical part of it. If they're not an active participant, then none of the above works. So they're the pieces that really make up an impactful care plan. And when I look at that list and reflect on that list, it feels like, certainly I feel like I can't do it on my own every time, maybe able to on occasions, but having that team-based approach to actually make the care plan impactful by capturing all these elements, I think is what makes it worthwhile from my perspective to get those patient outcomes, which, is my primary driver. But at the back of the mind, as a practice owner and a clinician, we also got to think about how the funding aligns with this. And I think it does, and you can make it align. We just need to think about it slightly differently. So why the changes? And I'm going to go through this really quickly because, it's a reform. We're 2 years into the reform. The next slide kind of talks about the NBS task force deliberations when they were thinking about making the changes in the chronic conditions management plan. A lot of it was about taking away the red tape. So, that's happened. The eligibility criteria have expanded. And certainly you haven't got the TCA requirements of having 2 or more other healthcare professionals involved now, either. So really what's happened since July is the red tape's been reduced. We've got a single care plan, either a new care plan or a review item number, and the ability to engage allied healthcare professionals got a lot easier. There's no forms to fill in. It's a referral letter like anything else, together with the care plan. And implied is in there, which was there before, but it's more explicit now, I guess, is continuity of care. So if you're My Medicare registered with the practice, you can only have a care plan with that practice. If you're not My Medicare registered with any practice, then it's your usual GP, which was the case before as well. So that's why the changes. And if we think about the context of these changes under the bigger sort of umbrella of strengthening Medicare task force, the next slide kind of shows, there's 4 components of strengthening Medicare. One's around increasing access to primary care. The other one's around encouraging multidisciplinary team-based care. The third one's around modernizing primary care. And the fourth one's really around supporting change management and cultural change. Because as these reforms happen, we need to think about things a bit differently. We need to think about doing things differently. We need to maybe change the workflows in our practices. And really when I take a step back and look at the evidence from where this comes, it actually comes from pretty good evidence. Sometimes the politics gets in the way, but generally the policies align to the evidence base. And the next slide picks one of those evidence bases, right? So it picks the 10 building blocks of higher performing care. And if you look at My Medicare, for example, as one health reform agenda, it actually is about patient registration, yes, but actually it enables population management, continuity of care, that rapid access to care. And actually we haven't highlighted it, but probably comprehensive and coordinated care as well. If we actually think about the chronic conditions management plan on the next slide and do a mapping of which bits of those evidence-based building blocks does it relate to, you'll see on the next slide, it actually covers many of the building blocks, all the way from data-driven improvement, patient registration, and team-based care. I'm not sure if the next slide has come up for people. I'm still stuck on the current one. Can I just, Kylie, can you,
Yeah.
there we go. The next slide's just come up, yeah. There we go. So you'll see, that it actually covers a lot of these building blocks. Each one of the building blocks has got a robust evidence base behind it. So if you think about the, some of the reforms, they're actually connected to some pretty good evidence out there. Admittedly, yes, politics sometimes skews things, but generally the evidence is connected to the policy. And that patient team partnership, which is a lot of what I was talking about in that earlier slide, is one of those fundamental building blocks as well. The next slide talks about what the changes have been since 1st of July, and I'm not going to go into these in detail, like we're there, but basically the item numbers change. We've got a single plan system, a simplified review system, the bureaucracy around and the red tape around getting agreement from allied health, etc., and faxing things off and getting things back has disappeared. It's become simplified with this sort of standardized referral like we do with all other things. The access to allied health hasn't really changed. It's the same entitlement there. There are some transitional arrangements between 1st of July when the new arrangements came in, and 18 months down the line, there's a transitional arrangement. The support roles in who can help with doing the care plans hasn't changed either. That's exactly the same as it was. So practice nurses, Aboriginal health workers can continue to help. The eligibility, as I implied earlier, in lots of ways is the same. It still allows clinical discretion, but the eligibility around TCAs obviously has disappeared. So it's really, the same eligibility as there used to be around GP management plans and around a chronic condition rather than a diagnosis as such. And I spoke to the My Medicare earlier. So, that's what's really changed. If we look at the next slide, I guess, really takes us through this in terms of the MBS item number and what's needed. I think I've covered a lot of this, right? And it's of course about supporting patients who have that structured approach to their care. It doesn't matter if the patients don't need allied health. This is the vehicle to help manage their chronic condition. I know in the past, many practices, including, practices I've worked in and colleagues would say, oh, we don't need to do it unless they need an allied health referral. Well, that's not the case. Think of the chronic condition management plan as the vehicle to support the effective management of their chronic condition, irrespective of whether they need allied health or not. If they do, if they have other members of the care team, it provides the additional value of being a coordination tool as well. The intent of the policy is around encouraging continuity of care, team-based care, and those regular reviews. And think of it as being a live document rather than a static document. The idea is we refresh this regularly, hence, seeing people regularly and doing those 3-monthly reviews. We'll go into the next slide, but I'm not going to really spend much time on this other than to say it's linked with My Medicare, and that's to support that continuity of care. The next slide, I guess, I'm going to just spend 30 seconds on, and this is so contextual because it depends on each practice and what they used to do before with GPMPs and TCAs and what they might do now and what they might do in the future with GPs, CCMPs. Building into the equation, we also got to think about how much time used to get taken up before with the red tape, which has now disappeared. We also need to think about in the equation with having a member of the team like a practice nurse involved in supporting the development of a care plan, how much time that releases from a GP to be able to do, and see other people as well. So there's lots of assumptions we need to build into this. But if you look at the just the basic hardline numbers compared to before and now, you'll see the red line is the amount under a GPMP TCA, and of course the amounts of revenue vary depending on whether you did a 721, a 723, and how often you did the reviews. The green line is with the new arrangements. And you'll see that depending on your individual context and scenario, for some people, the older arrangement was financially a bit better off, only really in 2 scenarios. If you did a 721 and a 723, or if you did a 721, 723 and 1 review. And in that final one where you did a 721, 723, and a double review of the 732. Other than that, every other scenario, the current arrangements are better. So again, I'd ask you to think about that and think about how can you think about moving forwards, leveraging what this graph tells you around, you're in a better position, generally speaking. It is very contextual to an individual practice, but generally speaking, you're in a better position as long as you do regular reviews. I think is the way I interpret a lot of this. If we go on to the next slide really just articulates the transitional arrangements. And look, I'm not going to speak to this. I'm hoping many people are aware of this because it is 4 months since we've been into this transition arrangement. We can come back to it in question and answer if needed. But I'm kind of itching to hear some cases, and I'm going to invite Kylie to sort of think about how we put some of this theory into practice through her own experience. So over to you, Kylie.
Okay. All right. Thanks, Paresh. So if we go then, yeah. So I've got a couple of case studies here. They're both very different. But this lady is one I've been seeing most recently. We've done, care plans for her in the past, but I've had a lot of involvement with her in between care plan reviews because of her current treatment history. So she's got a long-standing history of diabetes and a recent diagnosis of cancer, which she's currently undergoing treatment for. And part of her treatment is prednisone, which has skyrocketed her blood sugars. So having that care plan in place, she's, up to date with her screening process, vaccinations, bloods and all that sort of stuff, although she's having a lot of bloods now. But in terms of her diabetes monitoring, which I have been doing and using the 10997s for that, or the phone version of it, I've been doing remote monitoring for her diabetes. So I've put on a CGM, which she's had a couple of times now. So we've got that ability to do remote monitoring and still having that financial ability for me to bill in that. So it means that for the patient who doesn't quite live local, she doesn't have to come in face to face, and she hasn't laid eyes on a GP, I think, in the last couple of weeks, but I've pretty much been in contact with her for the last couple of weeks every second day in terms of her blood sugars. We also started insulin on her, and yeah, so she came in obviously for that insulin start education, but otherwise it's been remote monitoring. So having that ability for the care plan in place, the 10997s, it helps the practice out paying my wages, although it's, could be a little bit better in terms of payment. So yeah, she knows that she contacts me. She's got the ability to contact me by phone, via email, or she can come in face to face. So yeah, any thoughts on that, Paresh? Any comments on?
No, look, I think that's great, Kylie, and I think what you've really demonstrated is like the value you bring as a nurse, and that that follow up and the touch points you maintain, which are amazing.
I'm obviously more comfortable with diabetes management because I'm a CDE, and knowing that, and the patient also knows that they can contact me in that, and they know that they don't need to see the GP and still get what they need. So look, it's really good. If we've got time, I'll go to the second case study. Yep, so if we go to the next slide. So this is a very different spectrum of my lady. She's absolutely beautiful, 93-year-old. She's a DVA patient. We do the CBC program for her, so that there's a few different billing item numbers that we use for her, which allows for that constant follow-up. So I she's tech savvy at 93. She uses email and I love it. So we have some emails every now and then. She does like to come in because she likes to go out, and she's still driving, and she's absolutely fabulous for her age. She's not 93. So her care plan, that she pretty much comes in every month. So her care plan, although you don't have to do it, like it can be done every 3 months, but we update it pretty much every time she comes in. Again, we've got the 10997s for her, screening, follow-up care and all that sort of stuff. We've got what was involved in her care is she wasn't completely happy with her pharmacist. She was very loyal. So there was a lot of explaining on team-based care and, lack of communication from the pharmacy part of it. We ended up switching pharmacies in the end, and she is so thankful for me getting involved in trying to help her liaise with a new pharmacist. And we have a clinical pharmacist in-house, so there was a lot of communication using our clinical pharmacist as well, with her dispensing pharmacist. So yeah, she comes in every month to see the GP, but there's also been odd occasions she's come in between to see me because she had some questions and she was unsure. She didn't lay eyes on a doctor. She left with what she needed. So her care plan's kept up to date. She takes a copy. She doesn't take a physical copy. She prefers it emailed. As I said, she's tech savvy at 93, which is fabulous. So she does have a long, extensive history. On the slides, you can only see a very small snippet, but they're the main ones. She does have a lot of others, but there's not enough slides for that. So yeah, that we always, just to touch back on it, when we do our follow-ups, we always, at our care plans, we always book the next one. So whether it be the care plan appointment or just her general follow-ups, we make sure that we book that in as well. And usually the doctors here, like us nurses, whether it's me or one of the other nurses, depending on who the patient is, they're booked at the same time. So, yeah.
Thanks, Kylie. Kylie, there's a couple of questions, and I wonder, just going off what you just said, there's one question is really around how do you get people to come back to a review, because they've used their allied health up, they feel like they don't need a review, and the other one was really around all the components I spoke about. How do you sort of get a nurse to contribute to those components in a care plan in a time frame that's financially sort of sustainable and viable? So you said a couple of really interesting things there. So one is you book the follow-up appointment there and then.
Yeah.
Do you also within that sort of talk to the patient around the agenda for that review and what it's going to include and things?
Yeah, so we say, is it okay if we book your next one so we can go through, it could be your due bloods then, so let's book that in and you just have your bloods done just before that appointment, so we've got time to go through it. Or there was a patient today we saw who doesn't particularly like coming in, so they do everything at once. So we get him in every 6 months. So he had a list. He had bloods. He had a specialist appointment due. He also hadn't had his bone density. So great, that's fine. Okay, so we've done his care plan today, but then we said, okay, we'll book an appointment for May, and he's going to have everything done by May for then our next appointment. So that person knows that we've booked that next review, and he's got to have everything done, and he's going to get all those results at that next review.
So from a patient point of view, it stops them sort of having that coming back and going type of thing.
Look, if people don't have time, like people
Yeah.
are busy, they've got better things to be doing coming in to see us for, regular kind of stuff. If they can get everything that they need, then they're more inclined to do that. And people's needs change. So if somebody only needs to come in for a care plan every 6 months, they may not everyone needs it every 3 months.
Yeah.
It could be 6 months. So, and then, something could happen in their health and then they might need it every 3 months. So it's really dependent on what the patient needs.
Yeah. So really centered and then you sort out their referrals, their prescriptions, their follow-ups and things. So that's really good book. Any thoughts, Kylie, on that comprehensiveness of a care plan? How do you manage the time to try and make a care plan as comprehensive as possible, and capture all those components I talked about earlier?
Yeah, look, I try and prep before the patient comes in, so I've got a bit of a list. Sometimes it works, sometimes it doesn't. Some days just go completely pear-shaped, or the doctors run behind. It's usually the doctors are running behind. That affects my time management. But I do like to prep while the patient is not there. And yeah, I start by asking them, what are they here for today? Is there any problems, any concerns, anything they want to address, and get that on the list first, and then I follow up with my list.
Great. Thanks, Kylie. Look, we may come back to that maybe to expand on a bit later, depending on time. But, let's maybe move on, because we are getting a bit tight on time. And, it's messy, isn't it? This whole care planning process is really messy. And what you see here, and I appreciate you're not going to be able to read all the detail because it's very small font. The idea is not for you to necessarily read the detail, but to illustrate the messiness of care planning. And this was a process map I did with a bunch of practices a little while ago around how they were managing care plans. And it was, a lot of it was opportunistic, some of it was planned, a lot of it was done by the GP, some done by the practice nurse, the rest of the team not very, very involved. And I guess I think, my impression is what many people have done and have tried to do is to say, this is the old world. How, let's carry on and just adapt the new world to this sort of process map. And maybe we just need to rethink it. Maybe we just need to think a little bit differently. And so if we look at the next slide, I think this is our practice, this current process map. And I love the bit you said about preparation, Kylie, because what we've done is divided things into pre-visit, on the day, and post-visit. And so the pre-visit is a number of tasks that are done, which actually speak to what you were talking about with the preparation. So, and within our pre-visit thing, the GP and the nurse have a bit of a huddle as well. So I can say to the nurse, hey, with this patient, this is the bit I'm really concerned about. So can you please, focus some of the conversation on that, and creating that task list of, what are the things we need to chase up before they come, what were they supposed to have done last time, etc., and getting all that ready. Including any patient-reported measures we want to use, because we're increasingly using patient-reported measures, and I know you do that, Kylie, as well, which means the on-the-day stuff becomes a lot smoother. And we're now starting to think about how we can use technology to help with some of this as well, to make it a bit more efficient as well. So we can rethink the workflows, I think, to adapt them to the new world. If we look at the care plans and what needs to be in the care plan, again, I'm not going to go into depths around this because I think many people are aware. So if we look at the next slide, it's got some dot points around what needs to go into a care plan. I guess the other thing I've increasingly been thinking about, and this comes back to that conversation around how do we do things efficiently, because maybe we can't spend an hour for creating a new care plan, but how do we also get people to come back? Is that concept I spoke about earlier. This is a living document. It's not a static document. So maybe we do the things that matter and are priority for the GP, for the patient, for the nurse today. And maybe some of the preventative stuff, we say, we're going to do this in 3 months when you come back for the review. We're going to build this care plan to become more comprehensive as we review you as well. And so that can be another hook to incentivize people to come back. It's going to be person-centered, so it will vary from person to person. but that's something else one can look at. I think we can think about the individuals, and that's what we've done here in a case study approach, but we can actually move on and think about populations as well. So if we move to, a couple of slides forward, we've been thinking more around this kind of what's the population of our practice and how is it made up? And when we divide that population up, we've got some people with real high needs, right? Frailty, multimorbidity. We've got some with single or, a couple of chronic illnesses. Then we've got people at risk. And then we've got the rest of the population. The numbers are assumptions. If you take 1,000 as being the typical active patient population for a full-time GP, and then when you map that population pyramid to the services you can offer, you can see that we can offer chronic condition management plans to those top two tiers, right? Some of them you can do home medicines reviews as well. And so that's where getting the pharmacists involved and doing those 900 item numbers helps to the financial sustainability of it. Some of them may really benefit from having case conferencing. Kylie, do you do much case conferencing, being a diabetes educator and a nurse? And yeah,
and Tim, our pharmacist, he's involved as well.
Perfect. So what you're beginning to do is tap into those two boxes on the right by having a practice pharmacist and then yourself and then the GPS people to then be able to do a case conference around the more complex patients. So you can see how you can start to sort of think about the other services that are available to meet the needs of a person with living with a chronic condition. Some of the data tools you use, so Polar, etc., can help you identify these groups. And this is one I borrowed from Wally, who works with Kylie, a GP who works with Kylie, or you can have a spreadsheet. So that's okay. If we go to that next slide, this is a spreadsheet that Wally keeps for his patients. And I'm sure you've seen this before, Kylie. As a way of monitoring and tracking what's being done with every patient and where they're up to. In our own practice, if we look at the next slide, this is kind of stuff we've been thinking about for a little while since all the reforms started. And so we've done a whole bunch of stuff around, getting the team together to have conversations to try and make things more impactful. And so there's a whole bunch of stuff we've done. And then we've created a checklist, which we really started back in May, June time to help us think about the chronic conditions management plan. So next slide is our sort of checklist of things to be thinking about. And this is ongoing, right? So it's an iterative thing. So we started doing some of this at the beginning, but we continue to look at this. So for example, our referral letters and templates, we're still looking at them and we're refining them and updating them. We're beginning to use data from Polar and Cubico to try and identify more and more people that would benefit from a care plan. So, pulling it all together, there's a whole bunch of things I think that can help us enable us, I guess, to do this more effectively. So if we sum up those enablers, let's look at the next slide and the slide after that, maybe. For me, certainly a key enabler has been, and if we can just do the animation, please. A key enabler has been to think of this population pyramid and look at who fits into each one of those tiers and almost like create a patient register of people by complexity, by need, by their usual GP, because then we can start to do things more proactively. So that's been a really big enabler. The flow chart I shared with you earlier, which is again on the next slide, using this, and you can see that we've been kind of iterating on this. So using this as a way of thinking about it helps really get the whole team on the same page. And it means we can do some of that preparation beforehand, like you were talking, Kylie, which means things on the day get more efficient and effective. So this has been really useful for us to sort of map this out and do this to get the team on the same page, but also continue to do that sort of quality improvement around it. Increasingly, I think in the future we're going to see nurses being able to do more. So in our practice, thinking strategically, we're not we're thinking about how we increase our nursing workforce with the changes, because in the future we'll have nurse prescribing, nurses will be able to do more. And whilst that's the future, you can also do things now, can't you? So if we look at the next slide, this comes from Kylie's practice. There's a whole bunch of standing orders, isn't there, Kylie? Did you want to just very quickly speak to how do you use a standing order in your practice?
Yeah, so they started, it's probably, I don't know, a fair few years ago now that we had these. They're fairly basic. The standing orders, like the first one, I don't have my glasses on, is bowel screening. Like, we don't use our brains for that. Like, it's a screening process. We shouldn't have to worry about whether we order one or not. Like, it's a screening process. So we've made it, Wally's put in there that, okay, sure, the screening process, we can go and order one. ECGs, like ear syringing, probably the ear syringing is always hot topic on the nurses forums on Facebook. But yes, I'll throw myself under the bus. We still do ear syringing, and yeah, we get doctors to check afterwards. So if a patient books in with us, we've done ear syringing before, they can just book in with us for ear syringing. The doctors will pop in and check their eardrums afterwards. So, it's little things like that that sort of makes the flow better.
That's great. Thanks, Kylie. It's just the standing orders being used really by creating a bit of an authorizing environment. So you can get on as nurses and exercise your clinical discretion and ability to work closer to the top of your license than without the standing orders.
Like if we look in their ears and they say I'm deaf and there's no wax, it's like, well, there's no wax.
That's right.
Go see the doctor.
Yeah. And so if you look at the next slide, the other enabler is standardization. We've kind of thinking a lot about how we standardize templates and tools, so everyone's using the same template and the same tools, the same standing orders, and it's not like each doctor has a different standing order for you guys. It's across the practice, right? And then using those checklists on the next slide that I showed you earlier has been really a useful enabler. And then data, so using those tools summed up in the next slide, and I referred to Polar earlier, and it integrates with best practice, integrates with medical director, really useful to be able to use data and segment the population using that population pyramid, so you can target and focus the groups needed. And that pretty much brings us to the end. The next slide, I think, is a screenshot of the resources on the department's website. But I think we've got a little bit of time, 7-8 minutes for questions. We took some questions as we went along. So let's pause and Suzanne, I think you're going to moderate the questions for us.
So thank you for that interesting presentation. I'm just going to first of all reflect upon that idea of standing orders. As I put in the chat, related to medications, there's no such thing as a standing order under Victorian Drug and Poisons Act. But I would also say that idea of having standing orders related to other tasks is a really good way of thinking about the way that you define scope of practice within your clinics and how you assess competency for those particular activities that nurses are capable of, undertaking. We've all been trained to take ECGs. Do you know what I mean? That kind of thing. So think of standing orders in that kind of way. So that's the first thing I would say. The next questions, the question in the chats have mostly been about, they're under pressure. Nurses are under pressure for providing a quality of service under what they perceive to be a more limited period of time. So I think the idea of pre-preparing or understanding is a very interesting one. And I would like to think about that kind of idea of working as more of a team, how the practice manager and the practice nurses can work together to think through the process of what they're hoping to offer in care planning before you get to the point of actually seeing the patient. Is that something that happened in your practices, Paresh and Kylie, that kind of pre-planning and team meeting, deciding what it is that you want to do?
The change doesn't happen quickly, and we've been on this team-based care journey since 2015, or probably even earlier than that. And it takes time. You've got to have that trusting working relationship between your GPs and also your patients as well. So knowing what your GPs, knowing what the nurses are capable of is a really big thing, and having that trust both ways. I'm pretty lucky here. GPs, we do have that trust, and I'll always know if I'm unsure, I'll always ask. But yeah, it definitely takes time to have that team-based care approach. And you've got to chip at it. As nurses, you've got to prove yourself all the time, and show the GPs we know stuff. We know a lot of stuff, and we have different consults with our patients. So, and that has value. We have value in a care plan. We're not there to create a list for a doctor to go through. We're there for the patient's health and advocate for our patients.
Yeah, and I think, yeah, look, for me, trust is the glue that brings all this together. So, trust is really fundamental. How do you build trust? I think you build trust by having a bunch of team rituals. And a big part of team rituals, I think, for us is having lots of huddles,
Yes.
The doctor nurse huddling frequently. It's lots of touch points where the team has short, brief discussions. So the doctor and the nurse huddle frequently, the nurses and the receptionist huddle frequently. So, for example, every morning the nurse and receptionist huddle to look at what care plans are coming in that day and what can the receptionist start the process on. So, for example, patient-reported measures, we have tablets at the front. The receptionists give those to the patients and ask them to collect those. That sort of thing. The practice manager, nurses huddle on a weekly basis. So lots of team rituals. Huddles is a big part of the team ritual because they allow those conversations to happen quickly and really become the machinery and the motor for which drives team-based care. Yeah.
Susan's just put in a question and into the chat as well, asking about why the limit for the 10997, the practice nurse item number, is restricted to 5 per year. Any thoughts about that? It'd be nice if it was more. It'd be nice if it was worth more money.
Yeah, like that's how Medicare values us, I suppose. It's a bit unfortunate. Like I've got a lot of patients that I give free service to, essentially, because I have no more 10997s left. And it's a lot for more my diabetes patients that I see. So, that's a bigger problem.
Yeah. Look, I don't know the answer to that question. These are just my own thoughts on it. And one of them's a comment, the other one's a question. So how many of your patients with a chronic conditions management plan have all 5 10997s used a year? Just a rhetorical question, worth having a look at the data to see how well utilized it is. That's great, Susan. Fabulous. I think when government looked at it, their use across the system was limited. I think the other thing also that, and this is again a personal opinion, it's not a It's certainly no means a government opinion, but this sort of longitudinal care, we need to get away from the paradigm of transactional fee-for-service type of thing. Like every time I see a patient, I bill a 109.97 or whatever it is, to hey, when you need me, I'm there for you. So the kind of thing Kylie's operationalizing in their practice at the moment. And at the moment, Kylie, you described that as being a lot of free service. I think there is some serious thought around sort of block funding, whether that's an increase in the workforce incentive payments, whether it's another bit of block funding. Your case too, Kylie, talked about CVC program, and that approach kind of supports, gives some block funding to have those monthly touch points and things, whether it's that sort of arrangement. So there is talk about a different way of investing to support chronic conditions management beyond the 5 visits.
Like healthcare homes. Am I allowed to
I
say
would
that?
can I add to that as well? It might seem as if you're doing free care, but the reality is it's practice PR, and it's what keeps patients at your practice, knowing that they have a good relationship with the health professionals in there. So a lot of what nurses do is about raising a practice's profile as a caring one. I'm going to have to draw it to an end because we are at the end of our session. I'm just going to share my screen again briefly for a couple more things. I have a couple of resources for chronic disease management that I will send out with the email next week. I would like to draw attention to some of the resources that you people are probably already familiar with. Our infant chronic conditions management flowchart, which really kind of lays out that billing structure and where you should put in health assessments and care plans. We have an infant practice nurse resource, which does have broken down into it a lot of peak bodies for specific disease processes. So if you're looking for resources for patients, that is a great resource to keep on your desktop and to be able to go straight to the link. The last one is Melbourne Health Pathways. I'd really like to encourage all the nurses here to register for Health Pathways for 2 reasons. First of all, at the bottom of every pathway is a patient's resource page where you can go directly to resources that relate to a particular condition that you're looking for. And also, anytime you spend on Health Pathways, as you all have to be individually registered to use Health Pathways now, you can actually create your own CPD report and add it to the CPD time that you claim. You can see there's a little button down here that says create CPD report. So any time spent on Health Pathways contributes to your own learning. Okay, my last comments to say thank you to our great presenters. Thank you to Kylie and thank you to Paresh. We have a survey for you to provide feedback, good, bad, or whatever. We want to hear it all. So if you could either scan the QR code or go onto the link, this will also come out with the email in the next time. So we really value your feedback and anything that you would like to see in the next presentation or webinar that we have. We're in planning for our Practice Nurse Day next year, which is going to be in April. So look forward to seeing you all there. And I have another webinar coming up on the measles outbreak with Northeast Public Health Unit on the evening of the 26th of this month. So thank you to everybody for your time. And I hope you have a great rest of the day. Thank you, everyone.
Thank
Bye-bye.
you. Bye.
Thank you. Bye.